Hi, my name is Dr. Rob Warren. I am Assistant Medical Director with Care Dimensions, and today I'm going to talk about how to discuss hospice, having the conversation. Very often when we see patients, families, and even physicians and mention the word hospice, they look like they're deer in the headlights. And often this is really just due to misconceptions and misunderstanding of what hospice is. What I hope to do in this talk is to go through some of the basic myths about hospice, get a better understanding that will help both clinicians and families, and then talk about ways to have this conversation. And one of the first myths that we see when we mention hospice is people feel hospice is only for a few hours or a few days. The reality is, for some patients, it may only be a few hours or days because they were dying when they entered hospice and were enrolled in hospice. But for many of our patients, they're on hospice much longer periods of time. We have patients on hospice for 6 months. Sometimes patients are on even longer, and we even have patients that do so well on hospice that they, quote, graduate from our hospice program. Another myth that we often see is patients are worried that they would have to give up their primary physician, and that's not true at all. Patients can continue to see their physicians, and their physicians can continue to see them. One of the other interesting things that people feel, and physicians often feel, that patient needs to be homebound under hospice care. This is true for VNA services, but for hospice, we really encourage our patients to do whatever they can. Go fishing, go out for lunch, really live life to its fullest with the time that they have. We see patients with all kinds of diagnoses: dementia, COPD, heart failure, and there's more and more patients that are on hospice with non-cancer diagnosis than cancer diagnosis. Another myth with hospice is that you must have a do not resuscitate order. Many clinicians think this is true and are surprised when they hear otherwise. Patients do not need a DNR order to be on hospice. Most of our patients, by the end of their life, decide that they want to stay home, and they know that resuscitation wouldn't help, but this is not a requirement, a do not resuscitate order, to come on hospice. We often hear that if someone comes on hospice, both their physician, their family, and patients feel that they're giving up. The opposite is actually true in many situations. We know that starting earlier care at home with better quality of life, people actually live longer and do have the better quality of life. Hospice is covered by Medicare, and it's required to be covered under all insurances in Massachusetts. Many times we hear, oh, I don't want to go to hospice, I want to go home. Hospice is not a place. The majority of our care with hospice is done at home, but home may be an assisted living or a nursing facility. We, for short periods of time, can do what's called inpatient hospice, and that is done at the Kaplan Family Hospice House, and we are also building a new hospice house in Lincoln, and sometimes for short periods of time in hospitals. What Care Dimension has really done is what we call our open access. It's not always black and white, that people have to discontinue chemotherapy or transfusions or other things that are promoting their quality of life. We adjust this type of care, and patients can come on hospice, under hospice, and get the support provided through our team while they're still continuing these medications. Hospice has a much more in-depth care team. There's numerous members of the care team, and that is the RN, there's a chaplain, there's a social worker, there's home health aides, we have bereavement counselors, as well as complementary therapy. So it is really an encompassing program that takes care not just of the patient, but looks at the entire family as someone who's working together to keep their loved one at home or wherever they are. The first thing I always say is really try to get the people from the family that are important in making this decision present, because it's really difficult for anyone making these types of decisions not to have support of their family. We really want to look and say, does a patient and what does a family understand about their illness? If a family or a patient doesn't understand that they have an incurable disease, then that's the first thing, is really to try to express what's going on and whether this is an advanced illness and what options are available. One of the things that we often say to families is, and patients and families is, what are your hopes for the future? And you would be very surprised. People's hopes are very different, and they are not always what they think. We often hear, I just want to be home with my husband. I don't want to go back and forth to the hospital. Sometimes the goals that patients give or families give may be unrealistic. And part of that is to try to readdress these goals. As a clinician, I think that we should all give opinions on what is a realistic goal. And that doesn't mean we can't support somebody's goal, but if we know that it's not realistic, we can say things, we're going to hope for the best, but prepare for the worst, and really try to keep them in a frame where they continue to have hope, but they're not just focusing on an unrealistic goal. The worst thing that we often hear in these kinds of discussion is, there's nothing more that we can do, it's time for hospice. What we really want clinicians and families to focus on is not what hospice takes away, but all those different things that hospice will provide. And hospice provides not just the nursing care that we discuss, not just the spiritual care, a lot of the medical equipment, medications, and really 24-hour support. So 24/7, there's not someone there, but someone's always available via telephone or at 3 a.m. to come out to people's houses. And this actually really can keep people at home. One of the things people struggle with is, if my loved one is having pain or short of breath in the middle of the night, I really don't want to go to the hospital. And that's what our team is able to do, control symptoms in an emergency situation. I also would want to say, not all of these meetings through clinicians' offices or at home get resolved just on these short meetings. And that's where Care Dimensions has a palliative care program. And what we do is we meet with patients and families at all sites, hospitals, nursing facilities, assisted living and home, to further these discussions about hopes and goals for the future and help people get some symptoms under control if they need. If you ever have any questions regarding hospice or palliative care, Care Dimensions is available to help you answer any questions that you may have. Palliative care and hospice referrals can come from physicians, nurse practitioners, family members, clergy, anyone involved, and we're here to provide as much support as possible. Our number to call for these questions regarding hospice care is 888-283-1722.